Hi folks, I'm Dr. Tom Meade. Welcome to my video joint camp. You're here because you either have surgery scheduled, you're here for a second opinion, or you're just interested in learning about our outpatient rapid recovery kinematic total knee resurfacing program that I've been involved with and helped perfect over the past 18 years, along with doing total knee replacements for 36 years. So this video is going to help you walk through all the steps to allow you to have a successful surgical journey. First, a disclaimer. All the information provided herein is for education only. Any personal use of this information should be discussed with your physician or surgeon. All the information in this video is mine alone. It does not necessarily reflect the view of Lehigh Valley Healthcare Network. The objectives of this video are to set you up for success. So proper preparation prevents poor performance. Like any other high-tech industry, it is absolutely critical that you are prepared. Understand that an outpatient procedure, you're only in the hospital for a few hours. You are not like a traditional procedure in the hospital for a couple days where you can be overeducated by multiple specialties. You accept this procedure and the significant preparation that's involved ahead of time and after the surgery. You have to be committed to this. And we'll go over the predictors of success. First, we'll have the decision of when to have surgery. We'll go over our minimally invasive techniques, the risks which are real, the benefits of surgery, our less swelling, less pain program, and setting the expectations up for a successful outcome. So on your surgical visit where we decide to go ahead with surgery, we'll let you know that joint replacement surgery is appropriate for patients whose knee arthritis is debilitating, affecting the quality of your life, affecting the things in life you get enjoyment out of. And all the appropriate non-surgical options have failed. We'll confirm the diagnosis of arthritis. We'll go over how debilitating these symptoms are for your lifestyle. We'll go over all the non-surgical conservative methods that, of course, you would have had to review. And we'll go over your personalized ideal pathway. What is conservative management? Let's look at the knee like the picture on the right. When you were younger, you had a pristine knee. The articular surface, the cartilage on the end of the bone was nice and smooth. It made no noise and it caused no discomfort. This is a continuum of wear. This didn't happen in one day when you showed up in our office and say, boy, my knee is bad, I need a knee replacement. It's kind of like a tire on the right. It wears slowly over years. The tread wears down. It will slowly become bald, and then it's a problem when it gets down to the steel belt or the rim and you have metal exposed. Well, it's the same thing on a knee. As you can see, a damaged knee, it looks like Swiss cheese. There's little arthritic potholes that go down to bone, and they generate pain. All that cartilage floats around. It causes inflammatory mediators. The synovium becomes inflamed. And here's the misnomer also. This picture depicts why people will come in and they say, my knee is killing me, but my other provider said it's not bone on the x-ray. You don't need a knee replacement. There is so much misinformation out there. And part of this video is to dispel some of that misinformation. If you just look at that destroyed cartilage, you have a half a dozen quarter-sized lesions down to bone. But if you got an x-ray, the cartilage between those lesions can keep the bones apart. So on x-ray, it may not look like it's down to bone, but it's an end-stage knee. So there are multiple criteria, not just an x-ray, that dictates when you need a knee replacement, or as we call it, a knee resurfacing. I'll go over that in a little bit. So the decision is made not only by your symptoms, the exhaustion of conservative methods, the imaging studies, including other things besides x-ray, if they're necessary, which they not always are, MRIs or previous arthroscopy. All of those things in concert dictate whether you need a knee replacement. And I often have an answer when a patient says, how do I know if I need a knee replacement? I go, well, really, frankly, nobody really needs a knee replacement. If you look historically at the human race, we did very well up until 70 years ago without knee replacements. But now we live longer, we have better technology, so there's no reason to live with these limitations if you've exhausted the list of conservative management, which early on might just be modifying those things that hurt your knee. Don't do them. Let's use common sense. If that doesn't work, there's a plethora of over-the-counter anti-inflammatories that you can use, lifestyle modifications, exercise. There's a host of injections that have evolved that can treat the symptoms. They don't cure anything, but they can treat the symptoms. And if they treat the symptoms for 6 months, 12 months, or even a couple of years, it's certainly worth exhausting those options. You can use assistive devices if you have to, a cane, a walker as you get older, braces, knee sleeves. Certainly weight loss can be a critical aspect to prolonging surgery. And I'm a big advocate of nutritional supplements. We'll go over those, things like omega-3, turmeric, L-arginine, and even previous minimally invasive surgery. So that's sort of an outline of the things that bring you to this video if you are at the point of needing knee replacement, or as we call it, knee resurfacing. Surgery has complications, so you have to take this very, very seriously. Even though they're low, and over the years we have them down to a very low percentage, they can involve bleeding complications, blood clots, infections, and we will go over steps that we take to mitigate these and make them as low as possible. But I also say living with a knee, an end-stage knee, has complications also because you don't do as much. You don't exercise as much. It's not good for your mental health. It's not good for your physical health. You sit around, your cholesterol goes up, your sugar goes up, your insulin resistance goes up. So living with this and just decreasing your activity is not risk-free. Let's look at those factors that increase risk for your surgery, some of which you can change and some of which you can't. You can't change how old you are, you can't change your genetics, but you can change your BMI and your overweight. You can change your type 2 diabetes. You can change your insulin sensitivity. You can decrease your carbohydrates. You can improve your skin health. Anybody with skin lesions, psoriasis, scratches, cuts, heart disease. You can touch base with your cardiologist, optimize your cardiac health. Smoking is probably one of the worst things you can do for bone healing, complications, and infections. Know your kidney disease, liver problems. Do you have a bleeding or a clotting disorder, some of which can be mitigated with medications? GI problems, ulcers, that can alter what medications we can use post-operatively. Have you had previous infections, MRSA? Narcotic use, surprisingly, before surgery or long-term use actually increases. Hard to believe, yes, it increases your pain post-operatively. Previous knee surgery can increase your complication rate and your chance of stiffness afterwards. High blood pressure, we need under control so you don't have excessive bleeding, and that's just a partial list that we could look at to mitigate and optimize your medical condition pre-operatively. There are patient-specific factors and there are surgeon-specific factors that can help line you up for successful procedures. One of the most important patient-specific factors, and we will go over this several times, is having a care partner. Doing an outpatient procedure where you are only in the hospital or a surgical center for a few hours, you need a care partner at home. You don't need a lot of help. You're independent, walking, weight-bearing, but we can't just drop you off at the porch like a UPS package and expect you to do well. And that care partner has to be committed, at least for a few days afterwards. It would be great if they could review this video with you, review all the materials and handouts that we gave you in the office. We want them to be engaged with you. This will be part of a really successful outcome. Surgical specific criteria, I'll go over that in a second, but I can't emphasize enough that you as a patient have to be engaged. You have to commit to the education. It's absolutely amazing. Even reported in Consumer Reports. If patient engagement was a new drug, it would be considered the blockbuster drug of the century. And why is that? When we look at all the other preparation criteria, patient engagement can improve your outcomes, decrease your pain, decrease your complications, decrease your readmissions, and give you a successful outcome better than any other drug. Just think of that. The cheapest thing you can do is commit and become educated, and we'll give you all those materials. Our multimodal pain protocols have become so important over the past 15 years. We've almost eliminated the need for narcotics, especially when we look at the opioid crisis over the past 15 years, killing millions of people. So even short-term narcotics can have long-term dependency or addictive effects. They are necessary sometimes, and we will go over them. Our minimally invasive surgery techniques, and we individualize rehab. We'll go over that again in a few seconds. So patient education is focused on rapid recovery. This is not your grandfather's Oldsmobile. You're not in the hospital for 3 days. You don't go to rehab for a week. This is rapid recovery, which really decreases a lot of your complications. Critical, as we talked about, is non-narcotic multimodal pain management, which continues to evolve. My protocol has evolved significantly, and we continue to add to it even this week. Pain expectations. Pain is not terrible. We have it down much, much lower than the old days. The United States, for some reason, uses more pain medicine than any country in the world. Do we have more pain, or do we just use more narcotics? But our multimodal pain management addresses this. Family support, care partner, critical. So prehab is what I call activity before surgery. We don't do formal physical therapy before surgery. We find out that an end-stage knee will often get worse with dedicated, extensive exercises beforehand. Every knee is different. So what we tell people is don't dramatically or aggressively increase your activity beforehand. Do exactly what you're doing, and if you're not doing 20 to 30 minutes of gentle exercises 3, 4, 5 days a week, even gentle walking if you could, walking in a swimming pool, swimming, walking on a treadmill, anything that gently increases your activity, but use common sense. Even core strengthening and upper extremity strengthening will increase your fitness pre-operatively. Your home setup has to be very, very safe. It's not absolute, but it's a luxury to stay on one floor as much as you can, at least for the first week. Many people have steps. You can use steps even going home to get in the house or get upstairs. You'll go up carefully with a care partner, one step at a time. But again, it's much better to stay on one floor as much as you can the first week. Our DVT, blood clot prevention, has evolved tremendously since I was a resident. We used to use toxins and poisons, and the bleeding post-op was terrible. And really, the essence of our DVT, blood clot prevention, is not necessarily medicines these days. You know what it is? It's activity. We get you up every hour and move you around. Movement is absolutely key. And now we've known through multiple studies that 81 milligrams of aspirin is as effective as some of the toxic anticoagulants that we used in the past twice a day. Even now, studies have come out for higher risk patients, it's still adequate, and we just do not see the blood clotting or the DVTs that we had decades ago. Nausea and vomiting, almost non-existent since we got rid of narcotics. And urinary retention in men. Let us know if you have prostatic hypertrophy or if you're on medications. One of the things we never learned in medical school that's very important to me is perioperative nutraceuticals. Unless you had an interest in it, most docs know little about this because we had 1 hour of nutrition in medical school. We start these 30 days preoperatively. This is basically to help with pain, inflammation, and even infection. We'll go over this extensively, but the stalwarts of our nutraceuticals for years have been omega-3s. But again, you have to be careful with vitamins and nutraceuticals. You don't know what's out there. It's not regulated by the FDA. So we have researched and we'll give you recommendations of the pharmaceutical grade products that we recommend. And we don't stop these preoperatively. Depending on where you're having surgery, sometimes there's traditional information that they will call and say, stop your fish oil and stop your aspirin beforehand. We do none of that. We have found over 23,000 patients that we do not have increased bleeding, but we have a lot less blood clotting and DVTs with our protocol. We've added L-arginine along with omega together. They're synergistic. They decrease the wound infections. These are used in every intensive care unit to decrease wound infections and wound healing in critically ill patients. Also, major food companies now have pre-operative supportive protein drinks to help people recover from surgery. Well, you know what the ingredients are? Omega-3, L-arginine, and protein. So you don't need these drinks if you just take the supplements. We figured that out years ago. About 10 years ago, we've added full spectrum hemp, CBD, THC-free full spectrum. And it's been remarkable, and I'll show you what that helps from a pain, sleep, and anxiety standpoint. The endocannabinoid system is fascinating. I speak about this around the country. It's the most important system in our body that you never heard of because it isn't taught in very, very few medical schools. But what we have found is, unlike opioids, anti-inflammatories, which have huge side effects, there's virtually no side effects or minimal side effects. It really helps with preoperative surgical anxiety, post-op sleep disruption, which can occur for 6 to 12 weeks, decreases inflammation, helps with all kinds of pain, neurogenic pain, post-op pain, and sciatic pain. So these are well thought out nutraceuticals that we continue to evolve, learn about, and put into our protocols. Let's talk about modern knee replacement, or as we call it, knee resurfacing more accurately. So you'll hear about minimally invasive surgical techniques, but that doesn't necessarily mean it's a smaller incision. Although they are smaller than traditional incisions, small knees have small incisions. 6'7", 300-pound guys have bigger incisions. We make the smallest possible incision to do a perfect job. Years ago, there was this sort of trend to do minimally invasive surgery, try to squeeze it through the smallest incision. You know what happened if you made too small an incision to do the operation? They all failed early. So after 23,000 knee procedures, we know the right incision to make. But minimally invasive surgical techniques are not just the incision, it's how we treat the tissues. We're very kind to the tissues. We're not aggressive. We don't aggressively stretch them. We don't tear tissues. They don't bleed a lot. We don't dislocate the kneecap like we used to. We sublux it. We move the incision off to the side so it's not dead center so you can kneel on it. And then under the skin, we go in from the side. So all of these techniques are what we call minimally invasive. They decrease the inflammatory cytokines and mediators and improve your outcomes. So, minimally invasive knee resurfacing has a faster recovery. It has improved quadricep functions. We traditionally got rid of the tourniquet. We will use it now from 0 to 2 to 3 minutes only for the incision so we could pick up big varicose veins. But basically, that helps tremendously in decreasing quad pain and quadricep function. If you have a procedure that takes an hour or more with the tourniquet up, just that tourniquet alone causes a lot of muscle damage. So we figured these things out over decades. There's less pain, as we talked about smaller incisions, and you end up with quicker and better range of motion. Let's talk about the terminology and why this is more precise and more accurate than a knee replacement. We don't like that word because if you do a hip replacement or a shoulder replacement, you truly remove the whole joint and take it out. When I ask a patient, what do you think a knee replacement is? They draw those two lines and they say, I think you cut the knee above the kneecap and below and take it out and put a new knee replacement in. And that makes common sense. That's what the terminology conjures up in a patient's mind. But I said, that's not really what we do. If you look at the damaged cartilage, it's only on the end of the bone. So think of the femur and the tibia like a tooth. And that is what we do. We don't pull the tooth. We don't pull the knee and put a new one in. We just grind the enamel off, or we take the cartilage off and we put a crown on the top, we put a crown on the bottom, and a crown under the kneecap. So we're resurfacing all three compartments. This is more accurately called a tri-compartment knee resurfacing. Now, there are bigger knee replacement procedures like a hinge procedure where you take out the whole knee. That is not what we do. There's always some confusion. And patient go, oh, I'm having a partial knee replacement or resurfacing. I said, no. Remember, there's three compartments of the knee. If only one of the three is damaged, you can do a partial knee resurfacing, but that's less than 5% of all candidates. All the pictures show on this slide and hopefully explain why this is more accurately called a knee resurfacing procedure. Now with ChatGPT and AI, you can go online, and I've done this, and I said, please tell me, AI, is a tri-compartment knee resurfacing the way we do it a more accurate term than a knee replacement or a knee arthroplasty? And the answer is yes. Try it yourself. So we do get some arguments even in our own department, but this is the rationale that we use. So we went over some of the patient predictors of success, the care partners. The surgeon is very important also. If you look at studies, it basically shows that you need a minimum of 200 total joint procedures per year to have the lower complication rate. If you're not doing 200, statistically, you will have a higher complication rate. Fortunately, this is all we do. My team does 3 to 4 times that number in any given year. We do 90 to 95% of these as an outpatient. Our outpatient is not sometimes what the studies indicate, which is as long as it's less than 24 hours, it's outpatient. That's not what we're talking about. We're talking about going home after surgery in 2 to 4 hours, and that's 90+% of our patients. As we talked about, that takes a huge commitment from me, the surgeon, the surgical team, our educators, but also the patient and their care partner. It's rare that you have to stay 23 hours. Sometimes that's a social reason if nobody's at home, and 2 to 3 days in a hospital only for complex revisions. The other big change is that our procedures are no longer done at tertiary hospitals. Tertiary hospitals are big hospitals where if you're in a multi-trauma car accident, that's where you want to go. If you need a liver transplant, that's where you want to go. If you need a heart transplant or open cardiac surgery, that's where you want to go. But you are healthy. Most of our patients are very healthy. They have a sore knee. You want to go to dedicated modern joint replacement centers, or ASCs. They have the lowest costs, the lowest complication rate, and Lehigh Valley has a bunch of these hospitals. That's the only place that we operate. These are all critical points. Let me talk about kinematic knee resurfacing. So again, this is something I've been involved with Steve Howell. Steve really was the founder, the inventor of this procedure. He was my chief resident at Jefferson, so we go back a long time. We did a lot of research, published papers, talked in the sports medicine world, and now we are both into kinematic knee replacement. Steve wrote the book on this. I helped him write another book on this, but let me explain it real simply. You know, when joint replacements evolved, more than 50 years ago, it was a novel procedure. It helped people tremendously, and so they had to start somewhere, and they started putting knees in at a right angle to the femur and the tibia. So everybody ended up with a straight knee, and that eliminated a lot of arthritic pain, but it didn't feel normal because only 2 to 3% of the people have a normal straight knee. Most people are a degree or two or more bow-legged or knock-kneed. More women are knock-kneed. So what Steve figured out a while ago is that patients should feel more normal if you replace their normal anatomy. Let's replace their normal alignment before it was excessively deformed. And so Steve has been working on that for the past almost 20 years now. And finally the studies, the middle and long-term studies came out. And I was just part of a world expert meeting. And what we found out is that kinematic knee resurfacing across the board gets better functional results, less pain, faster recovery, better patient satisfaction immediately after surgery, and now up to 15 years afterwards. So this is something I strongly believe in it. Other surgeons have a different philosophy, but that's part of that mouthful of title of this video where we talked about outpatient kinematic total knee resurfacing. So we talked about kinematics, we talked about resurfacing. So I hope that is more clear. There's a lot of things that go into successful surgery. Anesthesia is very critical. So I've actually learned a lot about anesthesia as an outpatient because if you look at pain management, and we can do spinal anesthesia with the shortest acting spinal, and we use the short acting spinal that lasts only an hour, and that's the length of our procedure. And what happens is it blocks the pain message going to your brain. So you don't need narcotics in the operating room. You don't need them in the recovery room. And half of our patients never take a narcotic post-operatively. So we believe it's the best and safest option. It's not your grandfather's Oldsmobile. A lot of people, especially women, say, I had that when I had a baby. I said, you didn't have that. You had an epidural. This is different. You're not on a ventilator. You're not intubated. And even previous spinal surgery. I had somebody the other day that had a fusion from their thoracic spine to their sacrum. Boom, the spinal went right in between the rods. It was no problem. Patient was discharged to home that day. We do general anesthesia if you need it, but you will often need some narcotics. And as a surgeon, I helped develop a local knee block that we do during the surgery. So you wake up, hard to believe, comfortable. You move quickly from the stretcher to a recliner chair. You walk, you pee, you have coffee, and you go home. But critical is our multimodal pain management program. Physical therapy is critical, but not what you think. Physical therapy exercises that we figured out over the years how to maximize physical therapists, how to maximize our staff, and when to do each of those. But what we found out is no matter how minimally invasive our procedure is, we still violate the skin. There's inflammatory mediators. Knees To have less pain and early recovery, we have to get rid of the swelling and rid of the pain. And doing excessive steps, excessive strengthening early on, in my experience, over 23,000 knees, was adverse to early recovery. So come about 8 or 9 years ago, we stopped doing formal therapy the first week, and we found out that rest, elevation, swelling, these patients did much better when we saw them a week later. Everybody's an individual. A week later, if they're lagging in swelling or range of motion, we will do formal therapy. If they're successful on their own, we will just advance them. So our physical therapy is individualized. We love exercises and physical therapy, but one of the things that we also utilize extensively is lymphedema therapy. I learned this years and years ago in trauma, and the cancer folks learned this well before us, but we engage a team of lymphedema therapists both preoperatively and postoperatively. Swelling trumps everything postoperatively. Until we get rid of the swelling and the edema, you're not going to get range of motion, you're not going to get your strength back. And that's why anything that causes increased edema or swelling is adverse to early recovery. We'll go over that extensively. So our nurses have heard me ad nauseum. I sit down with every single patient postoperatively, and I review all of their postoperative exercises. Our team of nurses have heard me do this hundreds, if not thousands of times. They could verbatim repeat what I do, and they do it. We over-educate patients. They know my exact protocols. That's not always the case. If I send someone to an out-of-network therapist that's doing carpal tunnel, shoulders, backs, and knees. So this is critically important to us. We have the same team doing the same steps all the time. Both in the OR, in the recovery room, education, we do the same steps. They're repeated all the time. It makes our surgery successful, just like a NASCAR pit crew that changes the tires in 11 seconds. Our OR crew is extremely efficient. We repeat very, very few steps. Everybody knows the steps. Our nurses know all of our postoperative protocols. This is critical to the success. So our nursing staff post-op will go over the walker, how to do it safely. If you're doing stairs, we'll go over that. They'll actually wheel you out to the car, get you in your car, show you protective weight bearing, how to get up and down, keeping your knee stiff so you don't plop, when to bend it, avoid fainting, go over the basic exercises, and you'll hear all this 5 times on the day of surgery. So our nurse educator partners are critical. They understand exercises, they understand what we want, they understand edema control, they understand nausea prevention, and basically we don't give opioids. They don't see it that often. Men, if you're on medications for enlarged prostate, let us know. You could be at risk, for retention postoperatively. And again, our blood clot prophylactic surveillance program is excellent. Basically, 98% of people can be on aspirin twice a day for 4 weeks, and then 1 aspirin after that. Even if you're high risk, if you're on blood thinners for other reasons, we will adjust that for our DV. We just reviewed that. I can't emphasize enough having a family member, a friend, a care partner. If they ask, how long do I need help? It varies, but certainly the first week, but it could be 2 days, could be up to 2 weeks, depending on the patient's age and physical condition. The care partner has to understand multimodal pain management. It can be confusing with the number of non-narcotic pills at home and our vitamins and nutraceuticals, so we have to keep that straight. We want to monitor the medicines and the ice. You can keep ice on the knee full time, usually, except when you're sleeping, as long as there's a barrier like an ACE bandage, sweatpants, or pajamas between that and your skin. You don't have to take it off and on every 20 minutes. As long as there's a good barrier, you can keep cryotherapy on your knee. Fall precautions are critical. It's one of the most devastating complications. I always tell patients half tongue in cheek. If you come back in a week or two and all these instructions I gave you, you said I didn't do any of them, but I didn't follow, I would say that's okay, because we could always catch up by doing less rather than more, the first week or two. This is the durable medical equipment that's absolutely necessary. A front wheel walker, just like in the picture. Some of the nurses don't like the hand grip ones that look like a bicycle brakes, but if patients are used to using them and they're comfortable, they can use that. Cold therapy machines are not covered by insurance. They're not that expensive, but they hover around $100 or more. If that's a problem, ice can work just as well. It may be a little more inconvenient, but we will certainly make sure you have ice when you go home. Raised toilet seat or a commode chair is critical. You don't want to be hyperflexing that knee the first week on a low toilet. Bath bench or shower chair tubs are dangerous the first week. If you're stepping over them without a chair, you're at risk to fall, which is a disaster. I like the bench where you could slide over and wash yourself. And we've added edema wear stockings, just like that picture on the far right. We're starting to have patients get those preoperatively, bring it to the OR, and instead of an ACE bandage, it actually works better post-operatively, especially in those patients with venous stasis or edema. So infection we take very, very seriously. So that could be a devastating complication that nationally can be 1 or 2%. At our facility in Lehigh Valley, it hovers somewhere around 0.2%, but that's because we follow 11 steps for infection prevention. At our hospital, we do it all the day of surgery. If you have antimicrobial soap at home, that's great the day or two before, but we'll do the skin wash, nasal decontamination at the hospital. All these other steps, we will add powerful IV antibiotics pre-op. We don't give any post-op. Thorough skin prep, TXA, an amino acid which decreases blood loss. We are considering doing that for a week post-operatively to delay any bleeding and inflammation. We wear spacesuits, room management, limit the traffic, minimize surgical time. This is absolutely critical. Studies have shown that surgical time exceeding, I think it's an hour and 15 or 20 minutes, has a significant increased surgical infection rate. Like I said, our team works like clockwork. No matter how small the patient, how big the patient, we are so consistent from skin incision till finishing the procedure, somewhere in the 30 to 40 time period, minus the skin closure. So we are well, under an hour, which most centers of excellence are around the country. That significantly decreases our potential for infection. Pulse lavage with saline, Surgiphor, and iodine, Providine combination, vancomycin powder. The modern occlusive dressings are a blessing, and a wound vac in some revisions are high-risk patients. And medical optimization pre-op, that's absolutely critical. Get your weight down, stop smoking, get your blood sugar down, your insulin resistance down, all of these things. Take care of your skin, decrease infection. These are things you can do. Don't come to the OR with, 12 cat scratches on your lower leg. And nutraceuticals, as we talked about. We've simplified wound care. There's basically nothing for you to do. If there's an ACE bandage, it comes off at 48 hours. That's it. You have this beautiful waterproof dressing. It stays on till we see you. You can take a shower. If water gets under it, you could remove it, but almost never do I see that. These are well-sealed dressings. No need to wrap garbage bags or saran wrap around them. We don't use staples or sutures. So when this comes off, sometimes there's a glue or tape that will stay on underneath for an extra week or so, and you don't put ointments or creams on the incision until we tell you. Constipation is miserable. It all comes back to narcotics. Limit the narcotics. Some people have 2 or 3 bowel movements a day. Others, it's normal to have it every 2 to 3 days. but you don't want to go off your pattern. Add narcotics and you're going to get worse. I always say a little more knee pain is much better than miserable constipation, where some people end up in the ER to be impacted. Adhere to our multimodal pain pathway. It works. It limits constipation. Drink plenty of fluid. Stay hydrated. And if you have to, stool softeners, suppositories, or enemas can help. Nausea, we talked about that. If you limit narcotics, small meals, stay hydrated. Our anesthesiologist will go over this with you. If you've had previous nausea with anesthesia, I always say cross out anesthesia. It probably means you were nauseated from the narcotics. If not, our anesthesiologist will prescribe some other medications. And our CRNAs are great in the OR. They're the ones who manage our patients. They basically do our surgery intraoperatively. They know our procedure. They know all the steps. They know how long it takes my team to do a procedure. So they limit, basically my patients don't get narcotics in the operating room, and they limit some of the other agents, the inhalation agents, which can cause nausea. Post-op exercises, we talked about this. Here's our program the first week. It's a day off the first day. The second day, we give them these pictures. On the right, they do 4 exercises once an hour. They take 5 minutes. You do them for 8 hours. That's 40 minutes of activity over 8 hours, not 40 minutes of activity over 1 hour, which sometimes happens if they went to therapy. Then we use common sense. We know they have increased pain the 3rd or 4th day, so we back off the exercises. We use common sense. Just keep it elevated and nice. If it hurts, don't do the exercises, but you still get up and walk every hour so you don't get a blood clot. If it doesn't hurt that much, then you do the exercises, but you do them once or twice or 3 times or whatever you can do. And then the 5th and 6th day, you go back doing the exercises. You can walk a little more, but that first week, limit your steps. The more steps is not the better. Try to limit it to 700 or 800 steps, per day, not your 10,000 that you might have done, and increase 1,000 steps a week. But I'm telling you, limiting your steps that first week and the first couple weeks decreases that swelling. You'll actually, have a 3rd wave of pain somewhere around the 8th day, because that's when swelling is maximum. This is normal. Don't worry about it. You can see some calf pain, all normal, bruising. Don't worry about doing less if it hurts. Just use common sense. So again, our pain prevention actually starts a month ahead of time with our nutraceuticals, because our nutraceuticals decrease inflammation. Inflammation is the basis of all pain, but also 24 hours preoperative, we will load you with acetaminophen or Tylenol. You'll take 3,000 milligrams of Tylenol the day before. You'll continue your aspirin if you were on it. If not, we do start 81 milligrams 5 days beforehand. And we don't start anti-inflammatories, but if you are on them for severe arthritic pain, back pain, sciatic pain, you can continue, and we don't stop that preoperatively. Our post-op pain protocol is critical. We basically have eliminated narcotics for the most part. We're decreasing the prescription that we give to patients, but we keep adding non-narcotic pain medicines, including an anti-inflammatory, Tylenol, aspirin, gabapentin, and Jernvax, which is a new sodium channel blocker. All of these medications, and we'll give you the exact protocols. It's written on the slide, but you don't have to remember it. It'll be on a handout. Opioids only for breakthrough pain, and we are considering adding another amino acid for a week afterwards that limits bleeding and inflammation. And you will continue your THC-free CBD, omega-3, and L-arginine for a month afterwards. So this is great. It's all non-narcotic, but that's a lot of pills to keep managed. And that's why it's important to have a care partner that understands this. But let me reinforce that pain prevention is really our modern treatment, not pain treatment. We prevent pain with everything that I just went over. The most important foundation of pain prevention is cryotherapy, ice, elevation. The first week you keep that leg elevated, and ice, that's the foundation. Short walks frequently, and then we go through the plethora of non-narcotic medications that we've mentioned several times. We now have pain treatment. Narcotic pain medicine is for breakthrough pain only. I have colleagues across the state that are smart folks that we travel in the same circles, no longer give a narcotic prescription out. We do give narcotics out for a week just for breakthrough pain. Most of the people, half the people never use them. The other half use 3 to 5 pills when the block wears off, but we're even getting down to eliminating that. But use it judiciously. We don't renew narcotics after the first week. Okay, this is something I have to throw in there. Again, one of my good friends from upstate New York, Andy Wickline, has challenged himself to challenge us, his friends and colleagues, to collect 100 patients a million patients before he retires that use less than 10 narcotic pills for recovery. So I would like you, we'll give you this handout after surgery. If you count the number of narcotics that you've used, if it's less than 10, we would appreciate you joining the cause. Going online, marchtoamillion.com, put your information in there, and we're going to help Dr. Wickline hit that million patient mark. So again, our goals, your goals, 90% outpatient, and that means going home in 2 to 4 hours. Less than 10% will stay overnight. You're full weight bearing immediately. You're independent immediately, meaning you're weight bearing, go in the bathroom, taking care of yourself. But we like to say without the need for any help, 5 to 14 days. You can return to work in 2 to 6 weeks, depending on what you do. It could be longer if you have a labor job, but sedentary workers can be back sooner. Our goal is ultimately no narcotics. You'll reach the 90% heal rate at 6 to 12 weeks. Full recovery still takes a year or more. If you have carpal tunnel, you'll know it for a year. So, we want to be realistic and honest. It's a lot less than it used to be. It's still a real operation with real risks. Don't fall. It's an absolute disaster. We tell everybody this, especially older patients. It could be a sentinel event in their life where they spiral downhill. If we're doing 600 to 800 total knee resurfacings a year, we're back in the OR, 6, 7, 8 times a year from a fall, wound opens, quad tear, ruptures. It's not a good thing for anybody. People ask about the incision. You can barely see this incision. Most of this is genetic. Some people keloid. It looks bigger. And then you'll also see in many patients, why does the top part of the incision look thicker than the bottom? Patients will ask these questions. We give them this slide. The skin on the top of the knee and the bottom of the knee are different embryologically, and that's why they react different, and genetics do play a role. And you're going to be numb on the outside of the incision for up to 2 years. New nerves will grow in that area. That's absolutely normal. It may always be a little numb in the long run. Some people have no numbness, but I just want to let you know that's absolutely normal. When can I drive? You can drive whenever you can drive. There's no obligatory downtime. It depends on your skill set and confidence level. We do 22-year-olds. We've done 95-year-olds. Everybody's different. Some drive as early as 3 to 4 days. Others not comfortable for many weeks. It's basically up to your skill set, that you're confident in your reaction time, that you can react appropriately, practice in a parking lot, but that's up to your good judgment. So thank you. Look at this video as much as you want. There's a lot of information in there. We will over-educate you. We'll give you a lot of this information in handouts, in the office, post-operatively. Log on to mylvhn.org, set up your account. That's a digital communication pathway directly to us. We're answering these questions every single day, 24/7. We have nurse navigators that could answer if you call on the phone, but digitally is a better way. So we'll give you a handout in the office. Please, again, review this video often, and we expect a successful journey. Thank you for putting up with this, but it's critically important, I think, to give you as much information. And this isn't everything we can teach you. about our procedure, but it certainly takes a big bite out of the apple of information. So we look forward to helping you get a new lease on life. Thanks for joining me.